So then, so I'm going back to, because we did talk to Kim about Chinese herbal medicine and acupuncture for PCOS, and we do this regularly, and you treat people with cyclical progesterone regularly. So then the question can become, well, what should I do? Do I do one or the other? Can I do both? So a few episodes ago, we were talking about how there's different ways of helping PCOS, women with PCOS. And we know that the first line of defense, I'll call it, is the birth control pill. But there are other options, even coming from the Western medical model. And at that time, we were speaking to how Chinese medicine, acupuncture, herbal medicine helps. But we want to also come at it from another angle. And we're going to talk about cyclical progesterone. So I want to have Tanya take the lead on this, because I think you're actually doing this with your patients currently. I didn't actually ask you if you're doing this already. Are you doing this already?
Yes, I
Okay,
do.
cool.
I've been for years, on and off.
Yeah.
So cyclical progesterone is not the same as cyclical progestins. And if we take a step back and say, the birth control pill is usually the number one solution for polycystic ovary syndrome. So if you show up to the doctor and you're saying, oh, my menstrual cycles are irregular and I have acne, right there, irregular meaning your menstrual cycles are lasting more than 35 days apart, from day one to the next day one, or not lasting, sorry. They are not happening for more than 35 days.
Sometimes not happening at all.
Not happening at all. Mm-hmm. Or they're, happening too frequent and they're heavy, for example. And often when they are super heavy, and happening too frequently, less than 21 days apart. And if you have polycystic ovary syndrome, you have some other sign like excess androgen, like acne or hair loss, or or maybe on blood work it's showing high testosterone. So you have those two findings. That heaviness and frequent menstruation can be from not enough progesterone. So the brain is pulsatile, releasing pulsatile amounts of LH, so luteinizing hormone, this hormone that helps to encourage ovulation, and FSH is trying to be produced, but it's being suppressed by the LH, and then you end up with micro amounts of estrogen being produced by multiple eggs, but not one really releases. And so you get this withdrawal bleed on your own that's super heavy sometimes. And I've seen that where some women, they just don't ovulate or menstruate at all, but some have, anovulatory cycles where they'll kind of almost hemorrhage, or they just won't stop bleeding. And in those cases, it's so helpful to use the cyclical progesterone, because you can stop them from having this heavy bleed and losing blood and iron. So if that makes sense, I don't know if you've seen that before, but it can really kind of stop it in its tracks.
Yes. And so one of the things, and the reason why we say progesterone, because there's actually a lack of it. Right.
Correct.
So because your body's working really super hard, but it's not efficient. So you're the LH is too high. I don't know if is this too high level? I think we're okay, right? Talking about this.
I think so. And we should take a step back and talk where do hormones even come from? Because people don't know. So, but keep talking. I don't want to interrupt.
Right. No.
Share your thought. Yeah.
No. Well, just the point of there should be a balance between hormones, and it's a cascade of hormones. It starts at the hypothalamus, which is a certain area of the brain, and then it sends a message to the pituitary, which that's what releases the LH or the FSH, and then it communicates to the ovaries, and the ovaries produce estrogen. So when there's a miscommunication, that whole cascade of hormone goes wonky. And so what the heck do we do? So in the past, actually still currently, it's let's just go on the pill. Why don't we just stop everything? So of course that's going to work, right? But is that the best way of treatment? It's a standard treatment, but is it really serving you? And so what Dr. Tanya is talking about is perhaps if we help modulate differently, it's going to help your body in multiple levels and keep you healthier and longer. Right?
Yes.
Because not only is it for, just the menstruating women currently, but we're looking at perimenopausal women, menopausal women. So we could
puberty. I mean, if we think about it,
yes.
Right. Where do our hormones come from? And you said it, what people don't realize is that we are constantly changing with our hormones, and our hormones, like you said, estrogen and progesterone comes from ovulation. So from our ovaries. And so if you're not ovulating, you're not producing those cyclical healthy levels and production of estrogen and progesterone. So the first half of the menstrual cycle, our estrogen can fluctuate between 100 all the way up to 1,000 when you're ovulating, and then come down to and sit around 400 until you menstruate. And then you get that drastic drop in the estrogen, and progesterone goes up the second half of the menstrual cycle, with the first half being, is fluctuating between 2 and 4, and then going as high as 80, between 20 and 80 after ovulation. And it confirms ovulation. If you have progesterone production, it means that little sac left over from the release of the follicle, the egg coming out of the follicle, that there's that little leftover sac called the corpus luteum. In the first 8 weeks of pregnancy, it produces progesterone. And if you don't get pregnant, it kind of just, goes away and it gets absorbed. And that progesterone is really important to make sure that you don't have a very thickened uterus lining. If you have a really thick uterus lining, then you can have a very heavy period, and that would be from lack of progesterone and high estrogen. And that can happen often with women with polycystic ovary syndrome if perhaps the brain is saying, please ovulate through the LH message, and then instead of communicating to the ovaries, and if the ovaries are like, well, I'm not really listening because I have PCOS and I have high androgens, and so then you end up producing estrogen from multiple follicles, but none of them ovulate. So then you have this high estrogen. So to offset that, you can use progesterone or progestins. So the medical community will often prescribe progestins.
Should we distinguish?
Yes.
Okay, because there's a difference between what progestin is versus progesterone. So can you distinguish that before we carry on?
So chemically, progesterone is body identical to our progesterone, whereas, and some people call it bioidentical, but it's body identical. And then progestins have it's a different structure. So it doesn't identically match the progesterone. So it's not in our body that our body manufactures. And so sometimes progestins can act a little bit like an androgen. It can actually produce a reaction where you can get more acne, or you can get higher testosterone, whereas progesterone doesn't. In fact, it brings down androgens. It can help with hair thinning, and it can help bring down the dihydrotestosterone hormone that causes acne. And
which is an androgen,
and it works on the enzyme called 5-alpha reductase. So the enzyme that converts free testosterone to dihydrotestosterone, which women often have excess levels of when they have polycystic ovary syndrome.
Yes. So to bring it back down to plain English, basically, if we're going to look at progestin as a alternative versus progesterone in terms of treatment, which will you use? Progesterone, right? I mean, I think you guys are.
I will use progesterone because I can only prescribe progesterone. Even if I could prescribe both, I would choose progesterone.
Yes, absolutely.
There are minimal side effects to progesterone. Sometimes women will have breast tenderness. It helps with weight loss when there are struggles because it's an anti-androgen, meaning it brings down the testosterone, the androgens. And then androgens have been found to make insulin resistance worse. So if you're supporting your body by getting estrogens being produced and progesterone by ovulating properly and bringing down androgens, you can support insulin resistance and improve weight. And obviously the whole purpose of this initial conversation, we're talking about kind of stopping the excess bleeding, but you can also kickstart ovulation in this way as well. You can get ovulating.
Thank you for this. And I just want to go back to a point that you said earlier in terms of blood work and blood requisitions. I had a patient even just very recently that saw you, and again, no naming, but she says, oh my gosh, like when I spoke to Dr. Tanya, she was going to create requisitions for my physician that my physicians would never even think of. And so I just think that's a very important point, because the starting baseline, because you even alluded to it here, well, you didn't allude, you actually said it, Dr. Patia, who is a very well-known physician, who's actually he's from Toronto, and he has clinics in California and New York.
Dr. Peter Attia, yeah.
Peter Attia. And like you just said it, like he didn't really actually know about the cyclical aspect to what to watch out for, because I guess maybe day 3 of your menstrual cycle, for example, it's pretty standard when you do blood work, right? Or maybe
perhaps maybe you'll check FSH, right, and estrogen. That's it. Like you're not necessarily doing. So basically, the bottom line is that it was fascinating to find that Dr. Attia didn't even know how higher estrogen can go every menstrual cycle, within a cycle, when we're ovulating, and he was testing a woman's hormones who she was going through perimenopause, and he was trying to show her that for this particular month, her hormones were definitely showing ovulation. Her estrogen was high at 1,000. Progesterone had gone up after that during the second half of the menstrual cycle. But then months later, he tested again because her doctor, her traditional family doctor, said, we don't do that. And he tested, and she was postmenopausal levels, and her estrogen was less than 50, and her progesterone was like 2. And he was so shocked. He didn't realize that they just plummeted.
They can plummet, yes.
Yeah. Well, they do, not can, they do. They do.
Yes, that's how it works. That's
how it is. Yeah. And a lot of doctors and patients, general public, we don't know this. It's not that we are told when we're younger that one day when you go through postmenopause, your estrogen is going to go from, the cycling levels to almost 0. And that's why we have so many changes and shifts. And leading up to that, it's not just like it happens one day. There's a process of up to 7 to 10 years of perimenopause, which is very similar, if you think about it, to women who are struggling to ovulate with polycystic ovary syndrome.
Okay, so then let's bring it back to the cyclical progesterone. And,
yes.
You don't have a regular cycle. What does that mean, cyclical progesterone? Like you take it when in your cycle, but if you're not, like if you don't get a period, do you still do it? Like do you still go on and off? Can you explain more about that process?
Sure. So cyclical progesterone would be 2 weeks on, 2 weeks off. And you would take anywhere from 100 to 300 milligrams of progesterone during those 2 weeks on. And if you do get a period, but let's say you only started taking it 3 days ago, you'd still finish the full 14 days. If you're somebody who is trying to kind of work on your lining and you have really heavy periods, and kind of get the ovary, the androgens down and the ovulation happening. So you can do 2 weeks on, 2 weeks off. But after doing that for 3 months, if things are kick-started, you can then just switch to confirming you're ovulating, which we can talk a minute about how to do that, but confirm ovulation and then take it the second half of the menstrual cycle, because now you're ovulating and you are, and you're taking it 2 weeks before the menstruation shows up. So the luteal phase. And for some women, let's say you are ovulating, but you're regular but it's regularly irregular kind of thing. So like perhaps you're getting it every 40 days at this point now. You wouldn't take it from day 14 to 28. You would wait to the ovulation and you would take it the 2 weeks before your expected 40-day period. And how you would know that is paying attention to the egg white cervical mucus. That can take for, about 3 to 5 days of a change in the mucus production. When you go to the bathroom, you wipe, it's a slippery white. You might see that. And you might only notice it for a day, usually the day where it's the most, or that's the heaviest. That's usually an indication of increasing estrogen. And when it goes from present to not present, typically that means you're ovulating that day. And that would be a sign that you're into the luteal phase, and you should expect your period 2 weeks later. So that during that phase, you can use progesterone. If you have no idea and you've never paid attention to cervical mucus, or when you were wiping a slippery wipe, you should ask someone, a patient, they'll say, oh yeah, I've seen that. Didn't know what that meant. Didn't know that meant my estrogen was going up. But anyway, if they don't know or don't see, they can also confirm with a blood test to confirm progesterone. Some women can use ovulation strips, but for women with PCOS, often see high LH all the time. So it's confusing. Right. It's hard to confirm ovulation when you have polycystic ovary syndrome if you are a woman with high LH all the time.
So I'm going back to, because we did talk to Kim about Chinese herbal medicine and acupuncture for PCOS, and we do this regularly, and you treat people with cyclical progesterone regularly. So then the question can become, well, what should I do? Do I do one or the other? Can I do both? Your thoughts?
Both, for sure. I mean, it's very, definitely, I never say, oh, you can't do, what I'm doing, or stop what you're doing with the other practitioner. If a person's really trying to get their eggs woken up by the brain, like not just by the brain, but like reducing androgens and, getting them to ovulate again. And there's a multitude of things you can do. And you wouldn't just stop at cyclical progesterone. In Chinese medicine and acupuncture, you would work on lifestyle. There's so many things, because really you're trying to get a patient to be independent, relying on their lifestyle alone if possible, and maybe minor tweaks with vitamins and herbs once in a while if things get thrown off because of stress, right? So it's better to kind of throw everything at them at first so that we can really help them, because it's as I was mentioning, PCOS and states of anovulation, it's connected also to our neurotransmitters and our brain and how they're produced. And women are at much higher risk of depression and anxiety and,
heart disease, hypertension,
right? Low bone density, uterus cancer, like when they're not ovulating, but then also just in general, the feelings, the mood changes that can happen as a woman with PCOS. When you're not ovulating, you don't feel right. And the same thing can happen when you're going through perimenopause and don't know it.
When we do these episodes, it's providing you all the information so that you can make an informed choice. This is not medical advice. And at the end of the day, you want to go to your prescribing physician if you need to. You could seek out Dr. Tanya, myself, or any of us stellar people at Alive Holistic Health, and, make your own choice, because that's why we're here. Like, we volunteer to do these podcasts. Like, we don't make any money from this. We just show up because we truly want to make a difference in your life, and that, we provide the information.
Decisions.
Yeah.
Right?
Yeah. Thank you. That's all I have to say about that. Anyway, okay. So you said, so now personal, you're doing cyclical progesterone. So only progesterone, or are you also adding in the estrogen for yourself? Curiosity.
I am still an ovulating woman and make sufficient estrogen, and my cycles are regular. They used to be irregular, so they're very regular in timing. Yes. So I still make estrogen mid-cycle, ampoules of it. I do not need
estrogen. So we'll do another podcast. We won't wait until you have lack of estrogen. We're going to do a podcast about how people actually sometimes will use a combo estrogen progesterone. That's also an important topic. And we would love to, let's will it to happen where we can actually get Dr. Avrum, Bluming, and Carol to come on, who wrote the book Estrogen Matters. I was blown away. It was very new for me, because coming from the natural world, and for you women out there, it's like, who really wants to take drugs? And they coming from a point of view of care as well. Like, HRT back in the day, basically, was a gold standard of care. And then I forget
HRT being hormone replacement therapy.
HRT, thank you. Right. And especially for, menopausal women. And then it went the opposite direction and said, oh my goodness, there's a scare.
Initiative.
Yes. Yes. So we're going to get a very different perspective around that, and was an eye opener. And, Dr. Tanya and I are quite open-minded in terms of looking at both sides of the spectrum. And that's why we're here, because we don't believe in just one way or another. It's like, let's look at data. Let's look at our patients. Let's, you first, and treating you in a way that is safe and healthy, backed by science as well. And these guys provided freaking phenomenal science that had me say, because I am postmenopausal. And I'm like, I wonder if I should try estrogen progesterone together.
As long as you're within that 10-year window.
I'm within the 10 years because I'm 45 this coming year. And I went into menopause at 47. 45? I'll be 45 in a couple of months.
You mean 55?
55. 55.
I'll be 45. All right, did you just anti-age?
Oh, sorry.
I'm like 10 years younger,
I go backwards. I age backwards.
You do. You're like a vampire.
Benjamin Button.
Yeah, totally.
That's me. Yeah. So I'm turning 55 this year. I went into menopause 45. At 47.
Yeah.
So I'm still within the 10-year time frame. Right. So, so I'm gonna listen. I have the book. I'm actually gonna listen to the book, but we'll put it in the show notes. This 2-hour podcast episode, which was pretty mind-blowing to me. And so thank you for that. Totally and I've been telling all our patients, literally.
Yes.
I'm like, you can check out this podcast. So I'd love to bring on these, the authors of Estrogen Matters. So anyway, I think we kind of diverted, but not really, because the bottom line is whether you have PCOS or if you're like just menstrual, but not really menstruating very well, or irregular or anovulatory, cyclical progesterone can be for you, right? So, talk to Tanya or talk to Kim if you don't want to do that and do something more natural. Okay.